Good afternoon. My name is Brittany Berk. I'm the current andrology fellow at the Cleveland Clinic. I have the honor today of sharing the stage with Dr. Arthur Burnett, who's a professor of urology at Johns Hopkins. And we're going to go over the key takeaways from sexual dysfunction from the meeting. So I know that they say what happens in Vegas stays in Vegas. There are a couple of things I'll personally probably leave behind here in Vegas, but I'd like to go over probably some of the things that we can bring home with us. So to start, I'm going to just review some of the abstracts from the surgical management section. But first, I really want to acknowledge the collaboration that we've seen across multiple institutions and a lot of high-volume implanters. And the group was able to put out a lot of high-quality work, which I think is really helping us get the numbers that we need so we can identify how we can improve the outcomes for patients. So I think this is a great trend in our subspecialty, and I'm looking forward to seeing that continue. But I really think that Aricept took the main stage at multiple different sessions throughout the entirety of the weekend. But I wanted to highlight these two abstracts in particular that I think did a really nice job of looking at infection rates in penile implants with Aricept and looked at it separately based on which device was placed. So we have our antibiotic impregnated device and also the hydrophilic coated. And this was kind of born out of some of the in vitro data that was previously published before the weekend. So again, these came from a large database of about 12 different institutions and a lot of high volume implanters, and we're really able to get us the data that we were looking for. So to jump into each one individually, we'll start with the antibiotic impregnated device. So this came from a cohort of about 1,600 patients. Of them, 695 were the antibiotic impregnated device, and about 41% had Aricept utilized as the irrigation during the case. When they looked at clinical infection rates, which was defined by an infection requiring surgical explantation, they really didn't find any significant difference in infection rates with or without Aricept. And so the big takeaway from this was that Aricept appears to be safe to utilize as an irrigant for antibiotic impregnated device. Contrasted to the hydrophilic coated device, there were 885 of these devices within the database, and when they looked at clinical infection rates of whether or not Aricept was utilized, they did see a significant difference in infection outcomes with the utilization of Aricept. They went a little further and they looked individually at whether Aricept was used only as an irrigant or as an irrigant and dip, and really saw that the increased infection rate was accentuated when Aricept was used also as a dip. Their multivariable analysis also identified some patient factors, hypertension and priapism. But again, the big takeaway from this is that as opposed to the antibiotic device, it appears that the hydrophilic coated device may have increased risk of infection when Aricept is used as an irrigant, and especially when it's used as a dip in irrigant. So to come back to this, I think that this summarizes these two nicely. Dr. Burnett, what's some of the takeaways you have from this data?
Well, Brittany, thank you very much for putting this together. And certainly we know that infection with prosthetics is one of the most devastating things to handle in our field. So looking for better ways to achieve outcomes is really what we're all is our goal to do. The idea of using Aricept come along here as an antimicrobial solution, but this is very intriguing to suggest that there may be differences here with the different kinds of prosthetic devices that we have. Somewhat surprising here, I guess, even with the hydrophilic coating, is Aricept disadvantageous? I guess this is what we're trying to say. I guess the report is saying. Hard to understand exactly why that is. Maybe it interferes with the properties of antibiotics that actually can adhere to the device. So this is something I think we need to continue to look at, and further studies I think are warranted.
I agree. I think the other intriguing part of it is obviously Aricept. A large appeal of it is its cost effectiveness, and how do we balance the cost effectiveness and also making sure we're giving our patients the best outcome we can. So staying on the topic of penile implant infections, this was another abstract that was presented, again, from a large multi-institutional database. This was the PUMP database, which is the Prosthetic Urology Multi-Institutional Partnership. And the question they were asking is, does perioperative antimicrobials impact postoperative infections? And so when they took a look at this, you can see this on the left-hand side. It's looking at the specific antibiotics, and overall, it appears that most antibiotics are safe. The only one that did demonstrate an increased risk of infection were when quinolones were used alone for a penile implant. On the right is their multivariable regression, which unsurprisingly did confirm that a history of prior penile implant infection and diabetes did portend an increased risk of infection. But I think what was the most important thing to take away from this is down at the bottom, they found that perioperative antifungals were protective. And the reason I'm highlighting this is because throughout my training, from an antibiotic perspective, I've certainly seen vancomycin and gentamicin used at both the institutions, and that seems to be congruent with high-volume implanters in the country. But I've seen a lot of different variants of how antifungals are used for penile implants, whether they're used for just high-risk patients, diabetics, revisions, not used at all, or used in everyone. So what's your practice, Dr. Burnett? How do you interpret these findings?
Well, certainly some of the findings here are not too surprising. I think many of us use vancomycin and gentamicin. That's what I use in my practice with prosthetic surgeries. Although, again, we use different antibiotics depending upon antibiograms and perhaps what our institutional practices may allow. But I think quinolones, we think these are increasingly resistant organisms here associated with this antibiotic, so not surprising there. The antifungal risk being reduced, I think, is something to take note of. And typically we use these in diabetics or high-risk patients, or even revisions perhaps. But perhaps we should be doing this more regularly, and we should think about, what's the risk-benefit here, and the benefit may outdistance any kind of risk not to use antifungals. So I think this is illuminating, and I think it's an important study, again, from a collaborative work that's done in the field.
Yeah, agreed. So one more abstract that we've included that is about penile prosthetic infections. This was a study that utilized the Premier database, and the question they were asking is, does surgeon and center volume matter when it comes to reducing the risk of penile implant infections? And so they had over 18,000 men included in the study, and they grouped the patients by who the surgeon was that did the case and also where the case was performed. And they took the top quartile and compared it to the bottom quartile. And what they found is that it appears that lower volumes do portend an increased risk of infection, both surgeon and center. And so while I think that we certainly know reps are important and we encourage people to continue doing implants, what my big takeaway is that center plays such a big role. And so while us as surgeons feel that it is important, we control everything, we protect our patients, and we're the gatekeepers, there's another aspect that I think that we can be focusing on to optimize, and it is ensuring we have the same teams working with us in the operating room, that they're comfortable with the devices, that they respect the penile implant, similar to the way that we treat a lot of the orthopedic implants. And so I think that this is the center itself, I think, is important, and it's certainly something I'm going to be focusing on as I start my journey as an attending.
Yeah, so again, I think this is a result that's not too surprising, but it reinforces, I think, a general concept that we've had. But you make an excellent point that not only is the surgeon matter, but having the right team, and we should think about that going forward here, how we need to work within our teams to achieve the best outcomes. But again, the large database study, I think it is very supportive of a concept, and here's data that suggests that this is the right considerations.
So moving on, this was one of the abstracts that was presented on rear tip extenders. And over the course of my fellowship, I've heard a lot of, are you a cylinder guy or are you a rear tip gal? And I think this study tried to look at, are they technically the same? And so again, this is a multi-institutional study from the pump database. They took 840 patients that had not received rear tip extenders in one-to-one propensity score match to those who had received rear tip extenders. And the findings did suggest that rear tip extenders may increase the risk of complications and IPP revisions. And our multivariate analysis found that rear tip extender was an independent predictor of both complications and the need for revision. So obviously, rear tip extenders are necessary in some cases. It's impossible to never use them, but this might make those who prefer to have more rear tip extenders think twice about optimizing the cylinder size before going to the rear tips. it's a surprising finding, and I know that Dr. Burnett and I were discussing, is this because those cases are more complicated potentially? But I don't know, any other thoughts to explain this?
Well, this has been something that's been discussed in many of our society meetings that go back years. Some prefer rear tips, some don't. In my practice, I try to minimize rear tips because I want to get the most out of the inflatable device. But there may be arguments about, that whether it's more stable, less stable, how well it actually allows you to get the device surgically implanted. But I think the observation that we may be making here is, again, these are highly experienced surgeons in this pump collaborative. They may make their own decisions, but I think it may speak to the fact that there may be more complex surgeries just in general doing these operations. If you need to use more rear tips, maybe there are anatomical considerations, there may be some other complexities going on. That may actually be what's the fundamental difference here. But again, the shorter rear tips to me at least allow the advantage that you minimize where the rear tip, where the exit tubing comes out, where you get the most out of the inflatable device, and that tends to be my preference much of the time.
Awesome. Moving on to some of the non-surgical therapies, really a lot of the non-surgical therapy was a discussion around restorative therapies, mostly on shockwave therapy. So I'm just going to go over some of the findings from that. This was from the plenary yesterday afternoon that Dr. Burnett, I know you were part of the moderation for, obviously highlighting that the AUA guidelines see shockwave therapy as only being considered under an investigational situation, but we did have a panel of experts that took to the stage to kind of discuss where can it fit in still in a treatment algorithm. And I took this one slide from Dr. Honig, who had moderated this particular session, and he discussed a little bit about where he thinks shockwave fits at this given time. And I thought it was an interesting point. Obviously, setting expectations is always important in any of the procedures or therapies we're offering, but his point that he highlighted in this final slide, that maybe we use shockwave not as an independent therapy, but as a therapy to take somebody who's a non-responder to a PDE5 inhibitor or to injections and improve their response to these non-invasive therapies for those patients who might be too high risk to be able to undergo surgery, or for those patients who maybe just aren't ready to proceed to that point yet. So what do you think about shockwave?
Well, certainly, in our field of sexual medicine, we're just still trying to find, how we can cure ED. And of course, this is not a new topic, but it keeps coming back here. Where are we with this field? It's been around now for several years. We had a very lively discussion with the debate, and I certainly salute all the participants in that debate. But I think really where we are now is to still be hopeful, but we still need to define this better and perhaps optimize, the best device and the best tool, or at least a technique. Try to standardize protocols, do more rigorous methodology to really see what the outcomes will allow us to conclude. As of this time, it's still very investigational. We just don't know, and I appreciate some of the debaters with the session yesterday that really helped us think through just how rigorously some of these endpoints have been met and how well we need to continue to optimize the methodologies with regard to determining how successful this therapy will be. But I think we should not abandon it yet. I'd like to keep a positive light on it. I think that's what Dr. Honig is saying, and let's try to see where they can lead us.
Yeah, and you raise a good point. So a couple of the abstract in the non-surgical therapy session did go over some of the nuances of shockwave. There was one study that was presented that's a randomized controlled trial that did show no difference in improvements in IIEF scores for shockwave versus sham. But the second one listed under shockwave looked at the specific generator, and I think we, in general, know that some generators are better than others. Obviously, radial wave is typically not effective. And so this study looked specifically at that, and when they looked at the 1 month mark, it looks like electrohydraulic maybe had a slight advantage, but really at that 6 month mark, electromagnetic generators pulled ahead as the most effective, at least in terms of IIEF. The last study that's listed there was also a randomized controlled trial of about 21 patients. They looked at specifically patients with purely vasculogenic ED and said, how does the IIEF compare to either erection hardness score or penile Doppler ultrasound? And they found that erection hardness score was more concordant with IIEF. So I think that the takeaway from these studies is that, are we really studying shockwave in a way that we're going to be able to detect its benefit and should we be focusing more on specifying the generator, looking at erection hardness score, and really standardizing our evaluation of it a little bit more?
So again, I don't have much more to add than what I said, but I think that again, we're looking to try and develop restorative therapies, but we need to have some rigor in what we're doing. These are some insightful studies.
Absolutely. And then just quickly, PRP, 2 meta-analyses were presented that both really demonstrated no therapeutic benefit in terms of IIEF or penile Doppler ultrasound, which I think just suggests that we have a lot more to investigate for PRP.
Indeed.
So for testosterone replacement therapy, I think a lot of the data that came out thinking about prostate cancer is important for us to take home. What we already knew, of course, from the TRAVERSE trial is that TRT does not increase the risk of prostate cancer in men with a normal PSA. And a more recent study that suggests that patients on active surveillance can receive TRT without any increased risk of progression. So what did we add to it this time? Well, 2 studies, both coming from Dr. Bernie's group, demonstrated that testosterone replacement therapy can be utilized in not only men with low intermediate risk organ-confined disease after prostatectomy, but also higher risk non-organ confined disease with no increased risk of biochemical recurrence. There was also one abstract that was presented in a prostate cancer session that demonstrated a potential protective effect of testosterone replacement therapy in terms of reducing the risk of biochemical recurrence. So obviously, we want to optimize the quality of life of these patients after they've gone through their prostate cancer therapy. And then I think that these studies are really providing important information about how we can better manage their hypogonadal symptoms.
I like the way you frame this. What do we now think we knew about what's been done here with this year's work on the TRAVERSE and findings from some recent studies? We think testosterone in general can be safe, and maybe this reinforces that. And we need more studies to address this quality of life concern in men who've had radical prostatectomy or other therapies for prostate cancer, whereby there's been this dogmatic stance that nobody should get testosterone therapy. We need more good data like this. How it's protective against biochemical recurrence, that's kind of intriguing, but maybe more work needs to be done in that area.
Absolutely, a lot more investigation for that. And then lastly, from Peyronie's disease, during the SMSNA on Monday morning, Dr. Bayesh presented on a new Xiaflex injection technique that was initially described by the Mayo Group. This is just a slide from his talk. The aggressive modeling, I'll go into further detail about the protocol next. But when the Mayo Group looked at their outcomes comparing their old protocol to this new protocol, they did see a significant improvement in the curvature outcomes with up to 58% improvement. They also had asked patients just whether or not they felt that the Xiaflex helped them avoid having to need surgery, and there was a significant higher proportion of patients who received the new protocol who did feel that that protocol was able to help them avoid having to have surgery. So I work with Dr. Bayesh over at Cleveland Clinic, so I've had the opportunity to see this protocol, but just to go through it fast. On day 1, it's an artificial erection, mark out the point of maximal curvature, and then we dilute the Xiaflex actually in a higher volume in 0.8 milliliters. The second day, we do not induce an erection, but similarly dilute the Xiaflex in 0.8 milliliters, find that previously marked point of maximal curvature, and inject again. And then at least within 24 hours, sometimes we'll do this at the end of the day, or sometimes the next day, we bring the patient back, give them a good block, and really try to do some aggressive modeling by pulling forward and also bending the penis in the counter direction of where the curvature is. And then often we leave the bandage on 3 to 5 days from there. And this is actually the original study that Dr. Trost's team had put out. This is the protocol that they were following. If you scan this QR code, you'll be able to pull up the paper that he described it in and have access to this as well. It goes in a little bit more about his traction and post-procedural care, which I think is really important. So what are your thoughts on Xiaflex?
Well, certainly we're looking at trying to expand indications using this. This is a therapy that's been out now several years. And, when the trial was done, the IMPRESS trials are very restrictive to try and see is how successful it would be. Now that we're looking at some other potential ways of expanding indications and technical modifications that can achieve better results, I think this is a good example of that.
Agreed. So looks like our time is running down quickly, but I did just want to highlight these two studies. So this was a study looking at whether additional XIAFLEX after completing one full series of XIAFLEX is going to improve outcomes. And this is an ongoing randomized control trial that is offering XIAFLEX outside of the traditional 4 cycles, and they are seeing some improvements. So we certainly want to stay tuned and see what the outcomes are of this study eventually when they're completed. And then lastly, one other study that we included was looking at XIAFLEX and its utilization in patients who have complex penile plaques, and specifically looking at ventral plaques. Prior studies have demonstrated XIAFLEX is effective for a ventral plaque. I think the initial concern was always a urethral injury, but what's interesting is the study actually demonstrated that treating a ventral curvature with XIAFLEX actually increased the risk of developing new ED. So this may impact the way we counsel our patients and making sure that they understand those risks.
Excellent points. I agree with what you said.
All right, so this is just a summary slide of everything that we discussed. Dr. Burnett, I want to thank you so much for taking the time to go through this with me and chat with me up on stage, and I look forward to seeing everyone next year.
Thank you all.